Hi everyone, welcome to our February Grand Rounds. My name is Marielle and I will be your host for today. I'd like to remind everyone that this presentation will be uploaded and recorded and uploaded to our YouTube channel and Figure One account. And to access the PDF version of this presentation, please click the link included in the invitation. And to register and join our Figure One page, please use the link in the chat box that I will put in a minute, or the QR code included in the invitation. For our audience, you may turn on the feature called Caption on Zoom during the presentation to allow for subtitles. And with that said, I'd like to hand it off to our medical director, Dr. Pekia, who will introduce our speaker for today.
Thank you, Marielle. So glad to be here. I am medical director of global offsite care, also director in the Office of Academic Innovation and Telehealth and Telemedicine at Western University of Health Sciences in Pomona in the Los Angeles area of Southern California. And happy and honored today to welcome our guest speaker, Dr. Akurut Elizabeth Erina Emuku. And we will call her Elizabeth at her request. And Dr. Elizabeth holds a Master of Medicine in Pediatrics and Child Health from Uganda Martyrs University and Kozi, and a Bachelor of Medicine and Surgery of Mbara University of Science and Technology. She served the underprivileged together with her husband, Dr. Emuku, in the hard-to-reach area of Yumbe in West Nile at the border with Sudan. Dr. Elizabeth served the community for 10 years in this area before she went back to pursue her master's in pediatrics. She's currently based in Soroti District, where she continues to avail herself of and serve the population there. She has served at the Bethesda Hospital Soroti as a pediatrician for the last 10 years, with a particular interest in neonatology. Dr. Elizabeth is married to Dr. Emuku, and together they have 3 children. She is also a grandmother to a vibrant, active 18-month-old little boy. She loves cooking and particularly trying out new recipes. Today, she will present a case on birth asphyxia, a leading cause of neonatal mortality and morbidity in Uganda. She will discuss its risk factors, management strategies, and the challenges faced in low and middle income countries. Additionally, she'll explore how the introduction of telemedicine in the facility can enhance patient outcomes. So with that, welcome, Dr. Elizabeth, and we look forward to your presentation.
Thank you very much, Dr. Pekia. I hope I pronounce it well. Good morning to those in California and I think Bahamas. Good evening to those in Africa, Nigeria, Uganda. It's a delight for me to present for the first time the Grand Rounds, and it's exciting. And today I'm going to present a topic on birth asphyxia, which is something that is very common in our setting, in our low-income country of Uganda. And before I make the presentation, I want to make a disclosure that this presentation is mainly for educational purposes only, and there is no financial gain to it. And there is also no conflict of interest in regards to this presentation. Let's go to the next slide. Basically, birth asphyxia remains, that's our outline that we'll talk about. There's an introduction. We'll define birth asphyxia, talk about the epidemiology. We'll talk about the risk factors, symptoms. Then we'll particularly talk about hypoxic ischemic encephalopathy, which is one of the complications of birth asphyxia. Talk about its pathology and pathophysiology, because understanding it helps in management, how we can diagnose it, the differentials, management, and prognosis. And at the end, since we started telemedicine, I'll talk about how the introduction of telemedicine is very helpful in management of children with birth asphyxia and reducing its incidence. So birth asphyxia remains a major cause of neonatal morbidity and mortality, and most especially in low, middle, and income countries. And research has showed that between 4 to 9 million babies develop it annually all over the world. And according to WHO, it contributes to about 10% of neonatal deaths in low and middle income countries. And Uganda is one of them. Uganda has made many strides, great strides in reducing neonatal mortality from 33 to 27. A number of things were introduced from about 2016, and some of them included helping babies breathe the first minute, and that has dramatically reduced the neonatal mortality rate. However, birth asphyxia remains high up on one of the causes of morbidity and mortality. And it ranks second after preterm births. And that is very big. So that is why we are talking about it today. So what is birth asphyxia? Now, the English dictionary basically describes asphyxia as a condition that arises when a body is deprived of oxygen. And basically that is what birth asphyxia is. It is when neonates fail to initiate or sustain their breathing at birth. And the causes can be antepartum, intrapartum, or postpartum. And once they do this, we have a deprivation of oxygen, and eventually it leads to the cascade of events that happen. Why are we talking about birth asphyxia? Well, the incidence in high-income countries stands low at about 1.5 cases per 1,000 live births. But in low-middle income countries, it's about 10 times. That's about 10 to 20 per 100 live births. And that is why we are talking about it here today. The incidence in Uganda, as of now, stands at 29 per 1,000 live births. And over 25% of survivors suffer lifelong health problems. And this can range from disabilities, developmental delays, and behavioral problems. Some research has shown even 80% have suffered long-term health problems. For us to understand birth asphyxia, we need to understand who is at risk of getting birth asphyxia, because understanding the risk factors helps us prepare and anticipate a possibility of resuscitation, and this improves outcome. Antepartumly, mothers who have severe maternal hypotension are at risk, because that reduces transfer of blood through the placenta. And because there is reduced blood flow, we do not have enough oxygen. And at the end of the day, we have a child having birth asphyxia. Severe hypertensive disease in pregnancy, if the mother has a history of stillbirth, because many times we do not know the cause of stillbirths. And so it might be something in relation to the placenta. And so that is a mother that we need to prepare for resuscitation and a possibility of birth asphyxia. Young maternal age, because these mothers are very young and their bodies are not ready to deliver. They get tired, there is maternal exhaustion during delivery, and they are at risk of birth asphyxia. But also advanced maternal age. These mothers sometimes might get uterine rupture, because their uterus is very lax, and they also can get maternal exhaustion. So those are some of the antepartum risk factors. What about intrapartum? If a mother comes in with malpresentation, they're at risk, and so the clinical team has to be prepared for possibility of asphyxia or low gas cause. If a mother has prolonged second stage of labor, we need to be prepared for that. Postpartum, a child who has low birth weight, a preterm delivery, and a child who has poor resuscitation effort. There are symptoms of birth asphyxia, and basically the birth asphyxia impacts every organ system, because we said basically asphyxia is when, in simple terms, oxygen supply is cut, and our systems need oxygen to survive. So every system in the neonate's body is going to be affected. The most common that we'll be talking about today is hypoxic ischemic encephalopathy, and that affects the CNS. So these babies will have seizures, which usually occur after 6 hours. They'll be apneic. They will have issues of posturing, impaired sucking reflex. They'll be jittery. They also have metabolic issues of acidosis, as we'll see in the pathophysiology, how this acidosis comes in. They may suffer other electrolyte imbalances. They are at risk of pulmonary problems because of the reduction in oxygen. It affects surfactant production, and there's surfactant deficiency, so they are born with respiratory distress syndrome. They're also at risk of pulmonary hypertension. The GI, we have paralytic ileus, and they might even present with neck. Some of them will have hematological abnormalities. They might have hepatic, renal, or cardiovascular problems. So today we are going to concentrate on the hypoxic ischemic encephalopathy. And how do we define it? Basically, hypoxic ischemic encephalopathy, or in short, HIE, is the neurological damage that occurs as a result of birth asphyxia. And there is a sequel that occurs, and it takes place in different sequences. And that is what we call the pathophysiology. So we are going to look briefly at the pathophysiology, because understanding this pathophysiology is going to help us understand how we should manage these babies. Now, there are 4 stages in the pathophysiology of HIE. We have the primary phase, the latent phase, we have the secondary phase, and then we have the tertiary phase. Now, the primary phase usually occurs after a hypoxic event. And it's important to look out for risk factors, because those are the ones that will cause a hypoxic event. And when that hypoxic event takes place, it means that because there is lack of oxygen, we have a change from aerobic respiration to anaerobic. And because of that, there is reduced production of ATP. When we have reduced production of ATP, we have the sodium-potassium ATPase pump fail. And when that pump fails, it causes an influx of sodium into the cells. An influx of sodium will definitely bring water with it, and it will cause swelling and eventually lysis of the cells, and that is the early cell death. That is the primary energy failure. Now, of course, as you resuscitate this child, there is usually reperfusion, and that is when you have the blood supply restored to the brain, you have oxygen restored to the brain. We get to the latent phase. And during the latent phase, of course, before the latent phase, of course, there are some changes that occur even on the extracellular part of the cell during the primary phase. And that is depolarization of the postsynaptic membrane. And because there is depolarization, we have influx of calcium, and that leads to increased intracellular calcium and activation of the catabolic enzymes. And that will lead to oxidative stress and an inflammatory process. So following reperfusion, we definitely have, this is the point where management takes place. And this happens within the first 6 hours after the hypoxic event. And during this time, there is a resolution from the edema and the accumulation of glutamate that happened when there was depolarization of the postsynaptic membrane. And what usually happens is that it leads to rapid recovery of energy metabolism. And this is the part that we come in, and definitely cell energy metabolism is restored. If intervention does not take place, then the cells are exhausted, and it takes us to the secondary phase, which takes place between 6 and 72 hours. During the secondary phase, this is when we have the excitotoxicity, because we have the anaerobic respiration, we have accumulation of the excitatory amino acids, particularly glutamate. Definitely the calcium influx will continue, and then we will have the catabolic enzymes whose activity is increased, and that will be the proteinase, the lipase, and the endonuclease. And when these catabolic enzymes are increased, it causes release of free fatty acids, it will cause release of free radicals. We have DNA and mitochondrial death. And as a result of this, we have oxidative stress. Now, when we have oxidative stress and mitochondrial damage, it leads to apoptosis, which is programmed cell death. Now, what the brain does, rather than the brain as a whole being destroyed, the cells in seclusion begin to die, and that is programmed cell death. And when that happens, usually reversal is difficult. And the last one is the tertiary phase that happens after 3 days, and it continues for years. And during this time, we have a neurogenesis and cytogenesis defective. We have oligodendrocytes formation defective, and this results in permanent death of the cell. And why do we talk about this pathophysiology? Because we need to catch these neonates in the latent phase for us to be very effective. So how would we then make a diagnosis of HIV? A diagnosis is basically through history. We have to look out for risk factors, the risk factors we talked about in the antenatal history, antepartum, intrapartum, and postpartum. And usually in postpartum, these are children or neonates that have had a poor APGAR score. An APGAR score, some research has shown less than 3 at 10 minutes of life. Others have shown less than 5 at 10 minutes of life. If children have between 3 to 5 at 10 minutes of life, then there is a high risk of them having HIE. Also, postnatally, one of the things that we look at that will help us is their neurological assessment. And we'll look at that when we look at the SANAT staging. Some people have chosen to use the Thompson score. But a child that has a fetal heart rate that is less than 60 definitely is at risk of HIE, because that heart rate might not be substantive enough to push blood to all parts of the body and specifically to the brain. If a child needs resuscitation for more than 1 minute, or the first cry is delayed by 10 minutes, we are at risk. And if in the event that you can do blood gases, in our low resource settings, this might not be possible in all facilities, especially in the peripheral facilities. But if you can get a blood gas and you have a pH of less than 7 or a base deficit of more than 16, then this child is at risk of HIE. Now, that is the lab tests. Now, if you have neuroimaging, and MRI is the best imaging modality, which we do not have, at least in our setting. In the city, Kampala, we have it, but it is also expensive. So it might not be very possible for us. But if you have neuroimaging consistent with HIE, then that is a child that would think of treating for HIE. How do you evaluate these children? Now, usually when these children are born, in our setting, what we have done is that when we notice that the child has HIE and we have confirmed from the history, from physical exam, and from lab tests, if we have them, we want to follow them up. And we do daily Thompson scores. And usually we do them daily until the score gets to 0, or the child is discharged, because we might discharge the child before the Thompson score gets to 0. And usually the maximum score attained during the first 7 days classifies the severity of the HIE. The Thompson score definitely talks about the tone, the level of consciousness, if the child has fits, how frequent they are, the moral reflex, the grasp reflex, the sucking reflex, the respiratory pattern, and the fontanelle. And this one, for us, we have found it easier because it is easier also for our midwives to follow these in comparison with the SANAT staging. But this one assesses the severity of the perinatal asphyxia and predicts short and long-term outcomes. If a child has 1 to 10, after you calculate, because these scores go from 0 to 1, 2, and 3, you grade them. A child who has 1 to 10 has mild, a child with 11 to 14 has moderate, and a child over 15 has severe. Now, other facilities have used the SANAT staging. It still has elements of the Thompson, and I believe in the high-income countries, they probably use this more often. but it talks about the level of consciousness, the activity, and then we look at the neuromuscular control, and this we're looking at the muscle tone, posture, tendon reflexes. Then we look at the complex reflex like the sucking, moro, the tonic neck, and then the autonomic nervous system, where we look at the pupils, the heart rate, the respiratory rate, and finally the seizures. And it gives different staging. Now, understanding the staging helps us in management and knowing when we start certain treatments. So managing, if you look at those slides, it shows you when management should start. And of course, the topmost is talking about the different stages and the pathophysiology. And the one below, the color below the primary energy failure, those stages, is talking about when these treatments occur. Now, therapeutic hypothermia, which is very common in the developed countries or high-income countries, and sorry, that's blue. If you look at that blue line, that therapeutic hypothermia comes in the first 6 hours. Now, ideally, what we want to maintain is a temperature between 33 and 34 degrees Celsius. Why do I say it has done wonders in high-income countries? It's because it has shown to do well in high-income countries. But when it came to our setting, and I'll speak specifically for Uganda, a research was done where we realized that we are having more mortalities as we attempted to do therapeutic hypothermia. And because of that is something that we do cautiously. And why would that be the case? Now, when we look at our patient, our doctor-patient or nursing-patient ratio, it is 1 to so many. And ensuring that these babies who, as we looked at earlier, a majority of them are born with birth asphyxia, are monitored closely to ensure that this temperature remains between 33 and 34 is difficult. In high-income areas, we have, I think, the babies lie on blankets and it's controlled. They have thermometers that are probably pushed into the esophagus and they can watch those temperatures. But in our setting, you probably have to do rectal temperatures and at intervals. And there are high chances that you can miss keeping that temperature between 33 and 34. Research has shown in our setting that we are getting more mortality than if we did not do the therapeutic hypothermia.6However, the other treatment that we do is seizure management, and we need to expect those seizures after 6 hours. Usually it is at 12 hours. Now, some settings, when they see that there is a risk of HIE, they will give prophylactic anti-seizure medication. However, research has shown that does not work. It is monitoring these babies, and when we notice those seizures, and some of these seizures are subtle, we might not see them. Some of them are detected on EEG, which in our setting we do not have. So there are things like lip smacking that we look at. If a child is very jittery, if they are very sensitive, then those are things that we look at, and because over time we have noticed that those are children that usually are at risk of seizures, full-blown seizures. That is when we start the seizure management. And of course, there is the neuroprotective bundle, and that is how you care for children that have suffered this. Managing them in a quiet environment, reducing the amount of interventions that you perform on these children, ensuring that they do not have pain, ensuring that they are comfortable is important, because it allows the brain to recover. Because when they are under stress, it causes the brain to work so hard, and eventually it causes the need for the ATP, and this will continue to cause oxidative stress. So if it is possible to manage these children in an environment that is safe and quiet, that would be good. And that goes on from the time that they are born to the time that they are discharged. Now, other modalities have been introduced, and this is mainly in the high-income countries like melatonin and erythropoietin and stem cell therapies. But as for now, That one does not work for us in Uganda or in low and middle income countries. So generally what we do in our setting, we will not do the therapeutic hypothermia. We want to monitor closely for seizure activity, and when there's seizure activity, we give phenobarbital. We want to restrict fluid to about 15 to 20% of what they should be getting for the first 4 days. And the reason we do that, if we notice in the pathophysiology, we have that energy failure, which causes sodium influx into the cells and water comes along. So if you give so much fluid, that water is going to end up in the cells and it will cause more cell damage. So we need to restrict fluid to 15 to 20% of what they should get. Usually we will want to give nil per os for the first 24 hours because many times we do not have neuroimaging to show us for sure if this is HIE. And so we are thinking if this child has HIE, other organs like the intestines may be affected. So we want to rest those intestines until we give time for them to rest and they can recover, and then we can start the gavage feedings afterwards. And when we start the feeds, we want to advance them slowly. What are the nursing considerations? In our setting, like we said, because of the high mortality rate, we maintain normal temperature. I know in high-income countries, it has showed good outcomes because of what they have available. We want to monitor for seizures. We want to maintain IV access for administration of medication and fluids. We want to support their airway. We want to ensure that their sucking and swallowing is good before we can attempt feeds, because depending on the grade of their HIE, if it's HIE 3, they might not adequately take in those feeds and will get another problem of aspiration. And then we also nurse them in a quiet environment to reduce stress. What is our prognosis? Now, there are predictors of normal neurodevelopmental outcomes. And usually, if you have a normal serial neurological exam in the first week of birth, that is an exam either using the Sannert score or the Thompson, the Sannert staging or the Thompson score. Then if it is normal in the first week of birth, chances of good outcome are there. If we can have an EEG done and it is normal within 24 hours of life, of birth, then we have good outcomes. And if we have a normal brain imaging, we said the best imaging modality is MRI. However, a maximum Thompson score of over 10 in the first 10 days is predictive of developmental abnormalities at 12 months of age. That is 1 year. Other studies have shown that children with normal findings at imaging and are functioning within normal range at 2 to 3 years may have problems later on in performing higher executive functions, with memory, with social interactions, and subtle motor development. So these are children that we follow. It is not a child that you only watch during the neonatal period or while they are in the neonatal intensive care unit, but even after that, these are things that we need to even be talking to parents and letting them know that there is a possibility that their children will have this problem, even when the imaging might look normal or they look normal. So those are things that we talk about with parents. But before any questions, one of the things that I wanted to talk about is how telemedicine comes in handy in helping us manage these babies. Now, we were introduced to telemedicine on the 5th of October, 2024, and we have received some of these patients with birth asphyxia. However, there are challenges, especially when it comes to complications, because we have imaging technologists that have challenges in making some of those diagnoses. And so getting in touch with a facility that may have radiologists would be a good thing, because then I want to give a case in point of a child that had birth asphyxia and we were thinking of pulmonary hypertension, but we wanted to confirm that pulmonary hypertension. And we tried to get around to a radiologist to try to give us information. And this is through telemedicine. Eventually, we got in touch with one of the cardiologists in Heart Institute in Kampala. And of course, they said, yes, this is definitely pulmonary hypertension as a result of the birth asphyxia. And this baby was started on treatment. However, we started the treatment very late and we lost that baby. However, if we had this information early, as a result of telemedicine, this would not be a statistic of a child that we lost because of a complication that we probably would have managed. And that's why, and of course, like we said, therapeutic hypothermia doesn't work with us. What else has worked in other places that we can copy and introduce in our setting, and that we can do as we do these interactions, global grand rounds, as we interact with telemedicine, that goes a long way to reach to those underprivileged that would not have an opportunity to get to places where they would probably get that treatment very fast. Thank you very much.
Dr. Elizabeth, thank you very much for that excellent presentation. Very eye-opening and thought-provoking. And while those in attendance are thinking through what questions they might have for you, I'll start with one that pulls together your presentation on this condition and its frequency of presentation, and also how telemedicine, at least in your experience since, if I got it right, October of 2024, might make a significant difference. My first question is, would an automated capability of reading the X-ray or the ultrasound in that particular case that you mentioned, that you were awaiting an interpretation from a radiologist in Kampala, but by the time that you received that the child had declined and eventually expired, would immediate availability of an automated artificial intelligence enhanced reader, essentially much like an EKG, gets read by an AI interpretation? We're all accustomed to that. Would the availability of automated interpretation of imaging on site have made a difference for that particular patient and other patients like that young baby?
I believe we've not had an experience of using that automated interpretation, but I believe it would help because there was delay in making that diagnosis as we called Heart Institute and tried to get back, as we got back to the hub to try to see if someone could interpret. So if we had automated interpretation, I believe it would help. I do not know how effective it is because in our setting, we have not used it before. But if it has worked elsewhere, I think that is very helpful because sometimes you do not want to start certain medications without a definite diagnosis because there are many other things that probably a radiologist would have seen. For instance, I'll give an example. If we have seen pulmonary hypertension in that child as a result of birth asphyxia, this child might also have a PDA. But you might see the PDA and close the PDA, but also a PDA would worsen. Closing it might worsen the pulmonary hypertension. So those are the things that if that interpretation was made, or if someone who was more technical and advanced would help us interpret, then it would help us move forward in managing that child at the earliest.
Great, thank you. And I think for those in the audience, if I understand correctly, PDA, you're referring to patent ductus arteriosus, is that right? Mm-hmm.
Yes, please.
All right, we have a few minutes for any other questions, comments.
Yeah, Dr. Peck here. This is Princess.
Princess Doctor, thank you so much. Always great to see you. Thank you for being here.
Thank you very much. Thank you. I feel so proud for Elizabeth because she's made me really proud. She made me really proud. I feel so elated, that she was able to present such a wonderful topic. Dr. Elizabeth, congratulations.
Thank you. Thank you very much, Dr. Princess.
I am not surprised at all. I'm not surprised at all that you could do such a wonderful work because I know you too well, especially having launched your telemedicine recently, and I know what you could do. I know your facility, and I know what you and your husband is capable of doing. I just want to equip you with one of the parameters that you could use during a pregnancy. And that is, if a mother is hypertensive, you better watch that mother because that shows you immediately that she's going to have a preterm baby. And that is one of the indications of such baby encephalopathy babies. So watch out for mothers that are hypertensive or have the tendency of having high blood pressure. It's very important.
Okay. Thank you very much.
All right, we have a question from Owa Yezu. He asked, can I nurse a baby with birth asphyxia under an infant warmer in case of very low or unrecordable temperature? Thank you.
Thank you very much. I didn't get that name, but what we want to maintain usually is a temperature between 36 to 37. So if they are nursed under an infant warmer and we maintain this temperature and we don't get it above, that would be good. The other way that we would do it, because usually what we'd want to do is would put the babies under an infant warmer if they are hypothermic and we want to gain this temperature. But after they gain that temperature, we can nurse them in a bassinet and ensure that we maintain those temperatures and wrap them properly, because we don't want to get them to hypothermia, because then when we get them hypothermic, remember with the pathophysiology, we are increasing their metabolic rate. And once we increase their metabolic rate, that means they need more energy. And we already have a problem with energy. So maintaining their temperatures between 36 and 37 is good.
We have a few more minutes for any other questions. I know we also have some medical students from our university in Southern California here at Western U students. If you have any other comments, questions, or concerns, that would be welcomed. And
go ahead, Dr. Moses.
Okay, thank you very much. Thank you, Dr. Elizabeth, for educating us on the topic that touches my area. I'm so much interested in the brain. I've worked with Elizabeth for years and years, and indeed, the description that you've given befits her. I just have a concern, more of a dilemma. I know the brain, the component of sedation, is there any role in these babies? Because we know sedating the brain actually helps you lower the metabolic demands of this brain and could help you in recovery. I'm just borrowing this from probably a trauma perspective as we manage traumatic brain injury, and knowing that HIE in a way is also causing brain injury, though not probably traumatic in origin. And in the same vein, I don't know if there are instances when barbiturate coma could be induced in these babies if you're having, say, intractable seizures following this HIE. And then the other one is on the hypothermia. I'm just wondering what is unique about the babies in the high-income countries, because I'm currently in Mulago here in the National Referral Hospital in Uganda, and I see literally we are looking out for euthermia in every patient in the ICU or in the PICU or NICU. And then you guys in the high income end are inducing hypothermia. I want to believe, because even in the private setting where we are sure there is a 1-to-1 ratio in monitoring, we are still not inducing hypothermia. Is there something unique about the babies in the high income? And is it about their size? Would they be big babies, or those other drugs you're using that we are not able to use? Thank you. I just more of a, yeah, thanks.
Thank you very much, Dr. Moses. We won't want to answer for the high-income countries because it has worked for them. But like I said earlier, it is very difficult in our setting because from what I have heard, they usually do the core temperature and they pass a thermometer through the esophagus and they maintain those temperatures between 33 and 34. Someone on this call who's from a high-income country and deals in the NICU will help me, but that is what I have known. And that is maintained. And usually, by the way, it is done for the first 3 days. After 3 days, that might not necessarily be important, the therapeutic hypothermia. So it is maintained at that. And they also have systems to detect if anything goes below that or above that, which in our setting, we do not have. But I would appreciate if someone from a high-income country would shed light on this and see if there is any difference. But at least from the research that was done, actually in Mulago, there was more mortality in those that we tried to do therapeutic hypothermia. Then about sedation, based on your experience from trauma patients in your scenarios. Now, if we have intractable seizures, usually sedation is recommended. However, when we sedate, remember we need ventilation. Now, in our setting, low-income countries, having ventilation, even at our facility at Bethesda, we do not have ventilation. You're looking at the risk of sedating, there is a risk of actually pushing this child to the other side. It's something that we tread carefully. What we have done is try to control the seizures and using a step ladder approach. We'll definitely start with phenobarbital. If phenobarbital fails, we go to phenytoin. That has worked in our setting. Rarely have we gone to a place where we need sedation and ventilation, but there are challenges with doing that or even taking the child into coma. However, I believe it might be important because what happens when you sedate, you basically are making the brain dormant, and that allows the cells to recover. Of course, while you continue to give oxygen, ensure that this child is well ventilated and allow these cells to recover because brain cells are continuously being produced. So when you allow these cells to recover, then you have higher chance of neurological outcomes at the end of it. Thank you. I hope I've answered your question, Dr. Moses.
Absolutely. Thank you very much.
Hey, Marielle, I think we have time for one more question or comment, if there is one. And while we await that, I want to make sure I get the opportunity to again thank Dr. Elizabeth so much for a just tremendous presentation and question and answer session. And I couldn't agree more with the Princess Doctor regarding our thanks for your astute presentation and comments. Unless we have other questions or concerns, I think we can hand it back to Marielle to wrap up.
Yep, we have one more question from General Dr. Allen. He asks, would monitoring labor progress with CTG help prevent birth asphyxia? And is there statistical data to back this up?
Yes, there's statistical data to back that up because, of course, when you do CTG monitoring, it's continuous and it is very easy to note when you have a heart rate that is deteriorating or decelerating. Because usually what happens for a child to get fetal distress, what happens first is that you have an acceleration and then we have a deceleration. And that would be something that CT would pick out very early. Yes, it definitely plays a role in reducing our risk of a child born with birth asphyxia. Thank you.
All right, and I think that is our last question for today. And I would like to thank Dr. Elizabeth again for this very insightful presentation. And for our audience, this recording will be uploaded to our YouTube channel and our Figure One account, which you can find in the chat box and the MailChimp invite. And if you have any further questions for Dr. Elizabeth, please email me with the email provided in the chat box. And with that said, our next grand rounds will be on March 12th. If you are interested in presenting, please do not hesitate to email me. And as always, we appreciate your participation and thank you and have a great rest of your day.